Anna. So it's a real pleasure and privilege to introduce Dr. Anna Mazzeo. She's coming from Turin. She's an intensivist, but with a very strong interest in head injury. And she's going to give us a talk on brain death and organ donation. This is a very hot topic that comes again and again in the exams, because obviously you have to be right when you diagnose brain death. That's probably the ultimate diagnosis. So I'm very grateful that she has taken time from her work and come to us neurosurgeons to teach us. Thank you very much.
Thank you very much, and thank you to all of you for staying here for so long time. It's already almost 8 in the evening, but so thank very much for the kind invitation and for the opportunity to share with you my experience in this, that I believe is a very important mission for a neurointensivist. That is, when brain death has occurred, to shift from the care of the neurocritical patient to the care of the potential organ donor. So how I come from Italy and from Torino, and I work in a university hospital that is one of the largest in Italy, and this is also a big transplantation center. This is our 1 year number of transplant, and I will briefly discuss on pathophysiology of brain death, diagnosis of brain death, and variability in brain death determination worldwide. And here you cover almost all over the world. And then something about pathophysiological changes occurring in the organ donor and how we manage these patients in the ICU. We know that an adequate cerebral perfusion is essential for brain metabolism and to ensure brain activity. But we also know that several changes will appear in a patient after an acute brain injury. So our effort for this patient is essentially to try to restore and the neuronal function. In some patients, this will happen fast. In other patients, after some weeks of coma, they might evolve either in a vegetative state, where they will exhibit evidence of arousal, but no evidence of awareness. Other patients may evolve to a minimally conscious state, when they retain both dimensions of consciousness, but the awareness is fluctuating and inconsistent. And then there is a particular kind of patient that are the locked-in syndrome patients that are totally awake, fully conscious, but they cannot express this because they only retain high vertical high movement or blinking. But in almost 10-15% of patients after a catastrophic brain injury, independently, irrespective of the initial causa, this patient may evolve toward brain death. And this will happen because there will be a very important cerebral edema, and the increased intracranial pressure will spread all over the brain, and this will determine a compression of all the intracranial vessels. And at the very end, when the intracranial pressure will overcome systolic blood pressure, then cerebral circulatory arrest will develop, and the patient will die. And interestingly, it has been observed that there is a rostrocaudal evolution of this phenomenon. So we can have first flow arrest in the anterior circulation and then in the posterior circulation. But now, before going ahead, I would like just to clarify that when we talk about coma, we talk about life. When we talk about brain death, we talk about that. So how to diagnose brain death? There are several definitions that we can talk about, from the Harvard Medical School definition to the brainstem death of the UK, that is a confirmation of irreversible loss of the capacity for consciousness combined with the irreversible loss of the capacity to breathe. And this is perhaps the most comprehensive of the American Academy of Neurologists. That is, brain death is defined as the irreversible loss of all functions of the brain, including the brainstem. The medical standards for determination of brain death are very well defined, and it's very important that we recognize these essential prerequisites. So we have to have a certainty of etiology, and the neuroimaging should also be consistent with catastrophic brain damage. And we have to exclude the presence of confounders that can be alterations in thermal, cardiovascular, metabolic, homeostasis, and we have to exclude the presence of drugs. And the three essential medical standards for determination of brain death are coma, that is lack of consciousness and responsiveness, absence of all brainstem reflexes, and apnea. And it's important to remember that brain death diagnosis is essentially a clinical diagnosis, and it has to be systematic, rigorous, and complete. And it is extremely important that we document any step in the medical record. When we look for the absence of all the brainstem reflexes, we will define that each single part of the brainstem has died. And an important part of the diagnosis is also to perform the apnea test, that is to demonstrate that there is no respiratory effort when we have reached at least 60 millimeters of mercury of PaCO2. And also this need to be demonstrated with an arterial gas analysis. We will preserve oxygenation during this test that will last 5 to 8 minutes. If we remember that PaCO2 will rise 3-4 millimeters of mercury per minute of the connection from ventilator, we can preserve oxygenation either through a nasal cannula that will ensure apneic oxygenation, or using CPAP, continuous positive airway pressure. And this at the end of the test will confirm that patient have no spontaneous breathing. The presence of spinal cord reflexes does not preclude the diagnosis, because these reflexes are due to unopposed spinal cord reflexes after brain death. There are specific guidelines for determination of brain death in pediatric patients. The diagnosis cannot be made in preterm infants less than 37 weeks of gestational age, and in kids less than 1 year of age, we have the need of confirmatory tests. Confirmatory tests that are used, we said that diagnosis has to be clinical, so we order confirmatory tests only if clinical examination cannot be complete, or when even a single reflex cannot be tested, and or in children less than 1 year. You can use a different kind of tests. Important is that you have to demonstrate that you do not have anterior or posterior cerebral blood flow. So this is an example of an angiography Or you can use a SPECT, and this is an example of the whole black, that means that there is nothing inside the skull. Or you can use transcranial Doppler, and these are the typical characteristics of oscillating flow or systolic spikes or no flow in the case of brain death. And this is the image of a spiral CT scan. Some countries still require the determination of a loss of electrical activity in the brain by EEG. What is interesting to see is that even if the criteria to define the death by neurological criteria are very well known all over the world, there is a very big variability, a large variability in the determination, in the diagnosis in the different countries. And this is just an example on the difference in the use of ancillary testing in the declaration of brain death. And this is an example on how different can be, for example, in the United States, the number or the kind of specialists that are involved in this process. So almost everywhere, it's very well known that now it's time for an international consensus on this topic. So what happens in this patient when they evolve to brain death? We can see at bedside immediately and very quickly that what was stable just before, it will become very unstable in minutes and a few hours. And of course, patient will become hypothermic and they need to be warmed. Almost 80 to 90% of patients will have a big hemodynamic instability. And at the bedside, you will see immediately that the patient will become polyuric, and a lot of patients will develop pulmonary edema. And this is just a summary of the main causes of hemodynamic instability. That is the main problem in this patient, that because it may compromise the perfusion of the organs that could be donated. And pulmonary changes are also very frequent, either because of the ventilator-induced lung injury, either because of inflammatory acute lung injury that can occur after an acute injury. So this is the reason why only 10 to 20% of lungs may be used in multiple organ donors. And you will see also a lot of endocrine changes, and this will affect essentially vascular activity, so that we will have less response to a vasopressor in these patients. And diabetes insipidus is very frequent too. How do we manage this patient? So if the goal of our work in ICU was to recover the disease, when this has failed, we have to move to the goal of donor management, that is to maximize the gift that the patient decided to give when he was in life. And so to maximize the number and the quality of transplantable organs, and this we will achieve through maintaining an optimal organ perfusion and cellular oxygenation, maintaining hemodynamic stability, normothermia, and correcting diabetes insipidus, and maintaining glucose homeostasis and electrolyte balance that will be very soon compromised. There are very beautiful guidelines recently published, and hormonal replacement therapy is important when we have hemodynamic instability and when the patients will not respond to hypovolemia correction and to vasopressors. And pulmonary care is very important also, lung protective ventilation strategy. And in our hospital, we have a program for ex vivo lung perfusion when we collect these lungs before transplantation. If the donors are marginal, for 6 hours we ventilate the lungs in a closed circuit, and these lungs are circulated with a perfusion fluid that has anti-edema properties, so that at the end of this procedure, then the surgeon will decide if the lungs will meet the criteria for transplantation. Remember that goal is always sodium less than 155 if you don't want to hurt the liver. So it has been demonstrated that if we are able during the hours of observation, usually the number of hours of observation, it's another difference between country to country. For example, in Italy it's 6 hours between the two different clinical examination. If we are able to meet these donor organ management goals that are target of therapy, it has been demonstrated that the number of the organs is certainly improved. So just to going to the conclusion, we have to remember that brain death diagnosis is for clinician a clinical duty, a legal obligation, and a very important ethical value. And this it will allow to give hope of new life to the thousands of patients that are waiting for a transplantation all over the world. Thank you very much.
Thank you, really. It's a very complex issue. We are discussing it for many years. Are there any questions?
So, yeah, there are different protocols that are followed for maintaining the donors and for the brain death. In our hospital, we follow these guidelines that I showed. Which is your experience?
The team that is involved in this kind of diagnosis is like four or three on the specialists, neurosurgeon, neurologists, and neurophysiologists as well.
In Italy, we have three. As I said, the legislation is different everywhere in the world. So Italian law requires, so we do the diagnosis at bedside. The first diagnosis is done by intensivist. Then we have to communicate to the medical direction of the hospital that we have a case of brain death. And then the hospital will collect a commission of three doctors. That is, one is an anesthesiologist, one is a neurologist, and one is a medical legal person. And these three persons will repeat at the beginning of the 6 hours and at the end of the 6 hours all the test, the diagnosis. The only thing that is not repeated is the confirmatory test that demonstrates the absence of cerebral blood flow. That is not repeated, is only done one if it's required, but it's only in some cases. But the number on the kind of specialist is one of the things that is very different all around the world.
Systematically you use EEG and Doppler.
No, so that is another difference. Italian legislation is one legislation that still require EEG for everyone. So we do clinical diagnosis, and by law we need right now still to do the EEG for everybody. This is this is something that probably will change in the future, but right now our law requires it. The confirmatory test is only required even or for children less than 1 year of age, or if there is any confounder in the clinical picture. For example, if the patient is hypotensive and you cannot correct, or if you have treated patient with long-lasting drugs, but usually you don't use in this patient. And for example, if you have a severe maxillofacial trauma, even if you cannot perform a single test to exclude brainstem reflex, in Italy at least, we have to do a cerebral blood flow study. In all the other case, the diagnosis is clinical, but still in Italy is required the EEG for everybody.
You want to ask? No. Okay. Okay, same question. Thank you a lot for very nice lecture.
Thank you.